Good afternoon, everyone. You are all welcome in this research clinic seminar, which we are conducting under ARCID project. Today, we will have a presentation of Kristi Sidney, a doctoral student in Karolinska Institutet. The topic of Kristi's presentation is out-of-pocket expenditure for childbirth in the context of Janani Suraksha Yojana, a cash transfer program to promote facility births. Who pays and how much? Studies from Madhya Pradesh, India. Kristi is a doctoral student in Karolinska Institute, and she will soon defend her thesis. And the thesis is set in the context of larger EU project to evaluate this JSY program, a conditional cash transfer program, aimed to identify factors associated with participating in this program and to explore the reasons for participation or non-participation. So one of the sub-study of Kristi's thesis she will present. Let me also introduce the discussant. We have Tatiana, a head of master program and assistant professor at the School of Public Health of National University of Kyiv Molaya Academy at Ukraine. We welcome Tatiana for this, and we are thankful that she agreed to take part in this online clinic. We had also another discussant. Unfortunately, she will not able to attend this, but she has sent her questions, which will be helpful for Kristi. Her name is Elizabeth Lutje. She is public health specialist with a PhD in epidemiology from the University of Stellenbosch. So the program is the first Kristi Sidney will present her presentation, and then Tatiana will give comments on this presentation, and then the floor is then open for discussion, and we will also welcome comments and questions from other listeners. So I will now invite Kristi Sidney to present this topic. Thank you.
Great. Thank you, Vishal. Thank you for that introduction. So as Vishal mentioned, I am getting ready to defend my thesis, so this seminar could not have come at a better time. Actually, it's December 3rd. So I really appreciate the seminar, and any questions, comments, feedback, please don't hold back anyone that's attending. So let's go ahead and get into it. So as Vishal mentioned, today I'm going to present my fourth study, and we're going to look at the out-of-pocket expenditures in the context of a cash incentive program in 2 districts in Madhya Pradesh. So before we actually get into the paper, just to kind of set the context for everyone else, just to give a little background information, I'm going to talk a little bit about what reduces MMR, what reduces maternal mortality. So we know in the mid-2000s, basically 2 pieces of evidence came. Skilled birth attendants and access to emergency obstetric care was found to reduce maternal mortality. So most countries took this facility-based delivery approach, which in turn was supposed to help by providing skilled birth attendants and providing women to emergency obstetric care, was supposed to help reduce MMR. India is also an example of a country that did this. They have been promoting this facility-based strategy since around the mid-2000s. So if you take a look at this graph, we have institutional delivery on the left and maternal mortality on the right. And you can see in the early 90s to the mid-2000s, institutional delivery, which is the pink line, was more or less stagnant, or it was moving very, very slowly. In the inverse, maternal mortality was also decreasing. So around 2006, there was a program that was introduced by the government called Janani Suraksha Yojana. And this program I'll talk a little bit about this program a little bit later, but basically this program was giving cash to women to incentivize them to come to the facility. And as you can see, when this was implemented, only around 39% or so of women were delivering in institutions. So if India wanted to increase their institutional delivery and reduce their maternal mortality, there was quite a bit of work that needed to happen. So just to give an idea of the two different types of interventions for MMR, they usually fall into two categories, either the supply side intervention or the demand side intervention. Now, the supply side usually is focused on improving quality of care, and the demand side is usually focused on creating a demand for the actual services. And this is where we're going to focus today, on the demand side. So as I mentioned, there is this program called JSY. It was nationally rolled out in 2005, and depending on the state and how basically how healthy the state was, there was different targets. So in Madhya Pradesh, all women were eligible for this program. So regardless of their poverty status, regardless of how many children they had, they were eligible to have this cash benefit if they delivered in a public health facility. So once they came to the facility, and in this facility, theoretically, it's supposed to be free. So women are supposed to receive care and not have to pay anything. Within 48 hours upon discharge, they would receive this benefit for 1,400 rupees, approximately $23, depending on the exchange rate. And the idea behind this was, if you increase institutional delivery, you would reduce MMR. So now let's get into the rationale and the study objectives. So one of the first objectives is to describe the out-of-pocket expenditure for childbirth. So when we went to do this study, there were actually a couple of studies that had looked at out-of-pocket expenditures, but they had not looked at it once the JSY had increased. So as you saw from that, the graph that I showed, it increased extremely fast over a very short amount of time. So that was one of our objectives. The other was to understand, even though theoretically the service was supposed to be free, we know from previous literature and previous research that women still do have out-of-pocket expenditures in the public sector. So we wanted to understand if the incentive actually covered these expenses. Was it enough? Was it more than enough? What did that look like? And then thirdly, we wanted to look at factors that were associated with out-of-pocket expenditures, and then to look at if there was any inequalities in this actual distribution. Now, we chose to look at women, of course, who delivered in the program, but then also the women that delivered at home. We decided to exclude the women that delivered in the private sector for two main reasons. One, literature and my previous studies have told us that these women are very, very different, that they tend to be wealthier, and there's not the need, the same amount of need as the women at home and the women that are delivering in the JSY program. So for that purpose, we decided to focus on these two groups of women. So just a little bit about where the study took place. It took place in two districts of Madhya Pradesh. It's made up of Madhya Pradesh has 51 districts. And within these two districts, there were seven blocks. We used a probability proportionate to size technique to select the villages. And the main reason to do this was to ensure that each woman had the same probability of being selected. So it was to generate a as random sample as possible. It was a community-based cross-sectional study. We had two basically main ways to find out when the women had delivered. There was a call center that was set up, so there were people in the villages that were incentivized to report when a birth had occurred, and also there were research members that periodically went to the study villages to follow up on the births. So within this period, we had 2,779 births, and 2,615 women were enrolled in the study. And as I mentioned before, we're just focusing on home births and women that delivered under the program. So that excluded 226 women that delivered in the private sector. The questionnaire was administered between 2 and 7 days post-delivery. So let's talk a little bit about the main variable of interest. So this is the out-of-pocket expenditures. And we broke this up into 4 different categories. So the first category included medicine, supplies, procedures. These are what people usually refer to as the direct medical costs. And this is what the facility is supposed to cover. And the second category was informal payments. So these were expenditures that were reported as rewards, or I guess you could call them bribes, money that women paid to the family, the family paid to the staff for helping them in the facility. This is where we paid, for the women that delivered at home, this is where we categorized their payments to the traditional birth attendant who conducted their delivery. The third category was categorized as food and cloth. So this was food that was consumed during the hospital stay or within those 2 to 7 days post-delivery, and the cloth that was used to wrap the infant. And then the fourth category was transportation costs. So these were all costs associated with reaching the health facility. And most of these figures I think they're all converted into dollars, and we used the exchange rate that was present at the time of the study. So this is a little bit of a busy slide, but I wanted to give you an overview of of how much the women were spending. Now, it's very typical. We had the data was not normally distributed. It was heavily right skewed. So we're not going to take a look at the means. We're going to take a look at the medians. And the median out of pocket for all the women was $8. But when you break it up between the two groups, the median for the JSY women was $8, and the median for the women that delivered at home was $6. Now, this was significantly different at this level. If you break it down a little bit further, you look at the 2 districts, you can see the women coming from District 1 paid substantially higher than the women coming from District 2. The women in 1 paid $14, whereas the women in 2 paid $3. And then if you look at the women within District 2, there was no difference between the home and the JSY mothers. If we take a look at what actually was driving these costs, so what of those 4 categories, what actually drove the cost, we find that the direct cost was actually the smallest amount. So if you look at the left side of the graph, this is all the women. And then the middle 3 bars is District 1, and then the last 3 bars are District 2. If we take they have a similar distribution except for in District 2. But if we look at the total, we can see that only 8% was driven by this direct medical cost. And most of the expenditures were actually driven by this informal payment and the food, and obviously the food and the cloth. And then only a small proportion was driven by the transportation. If we take a look at how adequate was the benefit for the women that were delivering within the facility, we can see we took a look by quintile. And if you look at the first quintile, you can see that those women paid around $3. And when you took the cash incentive into consideration, they received $20 back. And as you look, as the women get wealthier, the amount they paid, their out-of-pocket expenditure increased, and obviously the amount that they got back from the benefit decreased. So the poorest quintile received around $20, and the richest quintile received around $10. Then we looked with the third objective. We were trying to understand what kind of if there was an inequality among the out-of-pocket between the 2 groups of women. So if we used a concentration curve for this, and you can see the line, the equality line is the black line that basically cuts the graph in half. And then you can see that both JSY beneficiaries and both home deliveries, their line occurs below the line of equality. So what this means is that there was a progressive system, and as women, the poorer women paid less out of pocket compared to the richer women, proportionally. And when we tested the difference between the two lines, the difference was not significant. So what we can say is that both out of pockets were progressive. Now, finally, the last objective was to look at the different predictors for out of pocket. Now, I mentioned earlier that the data was right skewed and that we had an excessive amount of zeros. So in order to deal with this, we decided to take a two-part model. So the first part of the model looked at all the women, and we used a logistic regression to see what were the odds of any out of pocket. So what we found was that women that were JSY beneficiaries had an increased odds of having out of pocket. If you delivered in District 1, you had an increased odd, as well as having a higher education. Wealth, caste, and birth order were not an indication of whether they gave no indication of whether you would have an out-of-pocket expenditure. In the second part of the model, we used a generalized linear model with a negative binomial distribution. And the reason we did this, again, was just because of the basically we couldn't use a standard linear regression because of the assumptions. We weren't able to satisfy the assumptions. So this model looked at only the women that had out-of-pocket expenditures. And what we found was that JSY beneficiaries actually paid 16% less than the women that delivered at home. And this was quite surprising. I'll talk a little bit about that later. But this was something that we hadn't seen in other studies. Women coming from District 1 paid twice as much, and although wealth was not an indicator of whether they would have an out-of-pocket, if they had an out-of-pocket, it was an indication of how much they would spend. So the wealthier the women were, the higher out-of-pocket. And of course, as expected, if you had a cesarean, you were more likely to have a higher out-of-pocket. On the converse, belonging to scheduled tribe and having more children were related to having a lower out-of-pocket. So just to kind of summarize a little bit, among the JSY beneficiaries, the poorest women had twice the net gain. So they were taking home around $20, whereas the wealthiest was taking down 10. And this is not surprising because as we saw in the model, the wealthier you were, the more money you spent. The program was pro-poor in the sense that poor women made proportionally less expenditures compared to wealthier women. And delivering in a JSY facility led to an increased odds of having an out-of-pocket. But among the women that had out-of-pocket expenditures, there was a 16% decrease compared to the women that delivered at home. And wealth was not a predictor of having out-of-pocket, but it was an indicator of how much the women would pay. So what does this mean? What are the policy implications? Well, I think we can say that JSY was successful in reducing, maybe even eliminating the financial access barrier, at least in this context. The program was effective in protecting the most vulnerable disadvantaged groups, meaning the women that were coming from the poorer households and the scheduled tribe. However, findings do suggest that other interventions will be needed in order to address the remaining access barriers, because it's no longer just a financial access barrier, but obviously there are other access barriers at play. So just a few things to kind of think about. A strength of the study. I think, like as I mentioned before, there haven't been any studies that have looked at out-of-pocket since so many women were delivering under the program. And I forgot to mention this earlier, but we had 77% of the women delivering under the program, and we had 23% delivering at home. So it's a quite high percentage of women that are participating in this program. The data collection occurred immediately after the delivery, so we think that this minimized the recall bias. And we also used a disaggregated data collection tool, which has also been proven to give more accurate readings of when trying to collect expenses. I think it's worth mentioning, as far as the weaknesses go, I think I misspoke a little bit here. I would say the generalizability is a bit compromised. I think our sampling plan is representative of the women that are living in those blocks, but I think we're going to have a challenge in trying to generalize further than at least those two districts. I think it's really important to understand in the context of India, it's very, from district to district, it's quite different. So I think it's really important to keep that in mind when you're interpreting these types of studies. We didn't collect the sex of the infant, which in other studies have shown to be a predictor of out-of-pocket expenditures. And we didn't have any data on the household income, so we weren't able to calculate whether or not the delivery actually caused a catastrophic health expense. Was a catastrophic health event, which just it limits our ability to see if the program is actually protecting women from these catastrophic health events. And I think that's about it. So I'd like to thank, obviously, the participants, my colleagues, and all the people that I have worked with throughout this study.
Okay, thank you, Kristi, for a short and very good presentation. And now I will invite Tatiana for comments on this presentation and the paper.
Thank you so much for an interesting presentation. I would say it made the picture clearer for me because I was reading the paper and some details within the presentations, they were better emphasized, I think. First of all, it was from the beginning, I like very much the slide about maternal mortality and skilled attendance of the births. So it's a great thing that you describe how the policy intervention, so rare, really works, are implemented, and it has a huge impact. What we have seen from the slide. I believe that out-of-pocket payments are really a major obstacle in healthcare services in India as well as in many other countries in Asian region as well as in Eastern European. But now I will shift and emphasize more some questions that I have at the moment to your piece of the study. First of all, from the paper and now, I have a feeling that the program and how you describe it, I don't see a clear connection with out-of-pocket payments. I will explain you why now. So you are saying that this program in the beginning is aimed at increasing the level of birth attendance at the facility, and as far as I understood, there were no policy objectives, policy goals to increase out-of-pocket payments. But then in the end, you also argue that...
Sorry, Tatiana, increase or decrease?
Decrease.
Decrease.
Yeah. Yeah. With regard to this, what supports the idea that the link between the program and out-of-pocket payments is not so clear and perhaps easy to explore is that among the percentage who are still having deliveries at home is only 1% who does not attend the facility because of financial barriers, right?
Yeah.
So there are many other obstacles which prevent them from going to the facility. So I think, and also like what I've seen from the paper, that it's about logical connection between the paragraphs, that your first paragraph is about out-of-pocket payments, then several paragraphs about this program, and then again about out-of-pocket payments. So I believe that you can explain a bit better the connection, why program and out-of-pocket payments are linked to each other.
Yeah. So I think, shall I comment? Shall I comment on that? Yeah.
You can, yeah.
Yeah.
Maybe.
So I think the main connection here is that it's supposed to be free. So they're not supposed to have any out-of-pocket expenditures. And this is it's well documented, and it's a known policy that women are supposed to have free delivery in the public sector. So I think perhaps I could have highlighted that. I think that was also the other discussant. One of her comments was that it wasn't clear up front that the women were supposed to have a free delivery. So I think perhaps that maybe if I had made that link a little bit earlier, if you had known that it was supposed to be free, that they weren't supposed to have any. So what happened, my argument was that if you were incentivizing, if you're encouraging all these women to go to the health facility, then, they shouldn't be incurring additional costs than they would have at home, right? Because I think what the argument from past research was that women didn't go to the health facility because they couldn't afford to go to the health facility. But that logic, that doesn't hold anymore.
Then the following questions.
Tatiana, does that make sense? Is that clear? Does that provide any clarity, or?
I think it's worth to mention that some more background, then the links between some elements of your study would be more visible for the reader.
Yeah. Okay. So you missed that piece about it being free.
Yeah, perhaps it was not so emphasized, or. Yeah.
But if you saw that it was free, then do you feel like the logic for the study is more clear, or do you think that needed to be laid out a bit more?
So you say that they are free. They have been free before.
Huh.
And now.
It's still free. It's still supposed to be free.
Yeah. Yeah, but then the question, what are out-of-pocket payments and how do they fit? It was my next comment. So if you're saying that de jure there is free of charge childbirth, and then you're saying about out-of-pocket payments, then you should perhaps also bring more details about formal policies so that there are no formal payments for the service. When I was reading the beginning of the text, and now when I hear I was listening to your presentation. First of all, when you said that home birth also required informal payments, which you consider as a payment for the person who assists the childbirth. So it raise some questions about what are the policies for practices related to those who assist. So in
you mean the women at home?
And at home, and as well as in the facility. So what kind of the package, I would say, in the facility that the woman is expected to be provided, like you are saying that food, clothes, and so on. So is it expected to be included in free of charge service?
Yeah.
Or how does it work?
No,
so
yeah.
It's also for me, I also do not understand what do you mean within clothes. Is it clothes for a newborn? And it's like, from my logic, it's clear that it's out-of-pocket payments of parents, but they are not so much connected to childbirth healthcare service provision, because it's like related to care of the child.
Yeah. Yeah. Okay. No, that's actually a really good point. So I think your first point about the policy and what's driving these. I mean, you're right. It's not the direct medical cost. So for the most part, I think the facility is doing a good job at providing the services that it needs to the women for free. What's driving, I think, a third of all the costs is the informal payments. So I think this is a really big problem, because unless we did a qualitative study that asked women why they were giving payments when they knew they weren't supposed to, and or if they knew they weren't supposed to, and they knew that they're not supposed to give payments, but they're giving because they feel if they don't, they won't receive care. So this isn't going to be a problem that is solved by better governance or making the women aware that they're not supposed to pay because they know they're not supposed to pay. So this is more, I think this probably has more facility-based implications in the sense that we need to understand why are they making the payments, and is there something that we can do to help reduce the need for these payments. I think that was the first part, and then the second part was I think about the food and the cloth. So we struggle a little bit as to whether we should include this, and we had many debates and we went back and forth. But it seems like in the literature, they often do include these types of other categories because they're trying to understand how much the women are paying. And so what happened, I think, with this one is that women actually, the food and the cloth came into the other category. But when I went to categorize the other category, it was just these two. It was just these two things that came in the other category. So that's why I actually ended up creating a separate category for this. But the cloth is purchased special for the child. So I guess to wrap the child, to diaper the child. So that's why we included it. But I understand. I get your point. I think it's important to highlight what that actually means.
Yeah, when I was reading your definition on out-of-pocket payments, I was wondering. So I was missing the information whether it's typical definition, whether it's common definition, or you introduce some changes to the typical concept and what is the specificity of that. So just to say in general, not going into details, in your study I'm a bit missing the focus, key finding of your study, because you're talking on the one hand about the, say, effects, because it's not really effects because the data is not longitudinal, it's cross-sectional, so you cannot say that the policy was effective because you have not studied it before. So what is the main focus? Whether it's description of those who used the program or who didn't use the program, comparison between the group of wealth, comparison between the regions, or what else? Because it really very much connected to introduction and discussion. So I think it's the key message that I have at the moment. So the focus of the study is a bit blurred.
Say again?
In a lot of, so it's not clear from a lot of, you have a lot of very nice evidences, but what is the major finding? It's not really clear.
Okay, so I thought that was quite clear, but I can see if I can tighten that a little bit. I mean, it was basically the three things that I presented at the end. So the fact that the JSY did defray the costs for the women so that they don't actually end up having any out-of-pocket. The program is pro-poor, and the fact that they're paying less than the women that are delivering at home. So to me, those were the main findings. Those were the key takeaways. But I can, I can see perhaps how to tighten that a bit more. I guess that came across more in the presentation perhaps than the actual paper.
Because you are talking about, I think, a very interesting finding, what constitutes these out-of-pocket payments of women, and that is major barrier. And if you are talking about policy implementations, you should think how to eliminate these barriers. So if we are talking about food and clothes, that is important part of out-of-pocket expenditures.
Yeah, and I think those are okay. I mean, those are the type of out-of-pockets that are okay. I mean, that's what we would expect. I don't necessarily think that's bad. I think I think this study is actually a bit more positive because I think it's showing that we don't have the direct medical out-of-pocket, right? Because I think if that number was higher, then I think we would have there'd be more of a problem, right?
Mm-hmm. Yeah. But if informal payments are still high, and perhaps, so we have no idea whether the share of informal payments have decreased with this program or increased, so or it's the same. And for informal payments, the other, so like if I observe that informal payments are about the same within home birth and within facility, then I would like also to understand what is the background of this important part of out-of-pocket expenditures, which are surely needed some policy intervention. So if it's more or less the same between facility and home, then it's perhaps something cultural. But if it differs between the region, what we observe, then does it mean that the culture between the regions differs, or the policies, because there are different layers of informal payments, like governance, like culture, like specificity of healthcare sector. So what constitutes this major difference? What I observed from your study, for me, it is the main focus of your study, because when we're talking about comparison of the program,
it's really interesting, because I think a lot of people like to take the paper down that route. And to me, that's not really the main focus. I think, to me, the main focus is more about the fact that, before we have made this argument that women can't afford to come to the facility, right, because it's too expensive. But we actually found that the women are paying less. And so to me, I mean, it's showing that there has been this reduction, right? The financial access barrier has been definitely reduced, if not eliminated. But I find this really interesting, because I think a lot of people, I presented this a little bit earlier, and they were also very interested about the breakdown. And I guess when we were in India, the government officials were also very interested as to what was driving this breakdown. So I guess that comes down to what you were saying. Is it cultural? Is it policy related? Yeah, those are really good questions, actually.
But I'm doubting whether people are paying less in terms of time, because we compared different groups and we're saying that one group pays less than the other. But if we're taking in mind that there were several deliveries of one person, so whether her expenditures have been increased, migrating from home to the facility, or not. So in this case, we cannot.
Opportunity costs.
Yeah, can be, maybe. But yeah, so
I didn't understand. Can you say that again?
So you're saying that the expenditures of women are decreasing if they delivering in the facility.
Correct.
It's correct when we say about group comparison. The group who deliver in facility, they pay less than those who are delivering at home. Yeah? But we are not saying that the woman, if she delivered before at home, her expenditures decreased after she delivered in maternity home. So it can be for one woman, it may mean that her expenditures could be increased or decreased. So we were not sure whether. So we should, when we are saying that these expenditures are decreased, we should say that compared to which group they are decreased. So not in general per case, per woman, per delivery, but we're saying that the price for childbirth is lower for those who are delivering in facility when compared to those who are delivering at home.
Right.
Yeah. Because we're not doing trend study. So, but the message that the price of delivery the cost is decreasing is like the background of it should be like trend study, cohort study, or something like that. So this longitudinal data will allow us to say this kind of conclusion.
Right. No. Okay. I'm sorry maybe I was just misspoke, but my point was that they spent less than the women that delivered at home.
And also there are some minor questions, like there is the certificate of it's $23 provided to the facility. Why exactly $23? It's based on the previous studies that it's like the service that the facility is, so it's calculated based on what? Do they also included some out-of-pocket expenditures observed before 2005, or it's only about manipulation cost?
Yeah, that's a good question. I don't actually, I mean, it's the national policy. So in these states that are considered high focus states, they all pay 1,400 rupees to the women, or $23. And the low focus states and the states that have relatively better socioeconomic indicators, they receive less. They receive, I think it's either 1,000 or 600. But how the Indian government came to that number, I don't know that. But I know that their intention, it's the intention of it is as an incentive. So it's not necessarily supposed to be used to cover out-of-pocket expenditures, but it's used as an incentive to get women basically to the facility. So they have also implemented these transport interventions. So they're providing free transport for the women. So actually, it was a bit surprising that the transport costs were as high as they are, because in that area they have this intervention that is supposed to transfer the women for free. So they've tried to kind of, come at the financial access barrier and the geographical access barrier together.
Perfect. And also about study design, I observed that there is no information what was the research instrument. So whether it was also part of the questions related to out-of-pocket expenditures or some other parts. So whether it was, so I think you mentioned that it was face-to-face interview.
Mm.
Yeah, but what was the parts of the questionnaire? So it was self-administered or filled by interviewer.
Mm.
What was the length of the interview, and so on. Then it will more or less give some details. So whether there were questions about medical parts of the childbirth, like whether it was cesarean or.
I struggle a little bit with this because it was used for a much larger study. And so we only extracted the out-of-pocket piece, but the actual study, the actual instrument covered morbidities, it covered a whole range of things. So they were collecting data on a bunch of different things.
Because as we know, when we are asking about informal payments, for example, it's important to know what kind of questions are asked together with this question, whether they are like stigmatizing informal payments and overall expenditures, or they provide some general overview of the experience of the person.
Okay, yeah.
So, like whether it's a part of corruption study or whether it's a part of healthcare service survey.
Yeah, exactly. Yeah. Okay. So we didn't get into the stigmatizing or the corruption. It was more of a health service survey. Actually, I think the primary objective was to assess morbidity, maternal.
Mm-hmm. Then when you described sample, I'm not sure whether it was a sample. So it's clearly that it's multi-stage sampling, and what you did. So you somewhere mentioned that it's a household. The sample unit is a household. But when you're talking about pregnant woman and you say that you collected information who gave a birth, then it looks like sample unit is a person who recently gave a birth. It's not household.
Yeah, I mean, you're right. It's definitely the individual.
And then the first stage of your sampling is well described, that it's villages, and then it appears that you are not doing sampling, but you are interviewing general population, because you interviewed all almost all. So it's not ideal general population, but general population. So all women who delivered in this area, you ask them these questions, right?
Yeah.
So it's not sample in particular, but it's practically the second part of your study is surveying general population, right?
General population in the sense, you mean
Of this region.
the general.
So sampling, yeah, there is general population, and from this general population, in your case, it's pregnant women who delivered within certain period of time, and you ask them all in your study.
Yeah, that's true. Yeah, so it's all the women that delivered within that time period. So
it's not just sample procedure, because in case you are saying that you sampled these people, then you need to argue and provide some justification for the size of your sample size and how you reached this, how you selected them example. But you practically have not selected them, you ask them all.
We asked them all. Yeah, so what was sampled was the village, right? So the village that we chose to go into was sampled, but then it was all the women within that village.
Yes.
Okay,
yeah. So for me it looks like that. And then you can generalize fully because you...
The village then is the sampling unit.
Yeah. I think sample unit is pregnant woman because it's or I'm a bit confused with this study design because village is not a sample unit because in your analysis you do not operate with villages, but you operate with the
individual
experience of pregnant women.
Right, the individual.
My suggestion is just to have a look on the papers which are already published and which use the research design related to interviewing the general population and to check how they describe this.
It's not general population, right? Because I mean, it's only women that delivered, so it wouldn't be. It's not. I mean, I couldn't have a man. I couldn't have a woman that didn't deliver. So when you say general population, you mean
general population of your study. So it's not population of the region. In case your study, you are interested in a certain group of people, women who gave birth, then it's general population of your study.
But then it's the general population, I guess, would be of, like, for example, Ujjain, which is the district that we use. So the general population would have been all of the women within Ujjain. But because, obviously, we didn't have the resources to do every single woman within that entire district, we selected villages within that district.
And then it will be perhaps quota sample, because it's not related to size or something like that. It's your decision which quota sample, which is not so much representative. So the general population of your study and sample population, they are important.
No, it wasn't quota sampling because we did PPS sampling, and so we did we structured.
It was quota on the step which relates to selecting 2 regions. So you selected 2 regions, but not all regions, and proportional to size. So you could interview all women.
Those were purposely selected. Yeah, the districts were purposely selected from the beginning. Yeah.
So there are several types of sample, like random, stratified, cluster, and quota. And I think it's about quota because it's related to purpose. So it's not linked to.
I don't think I would agree with that though, because I mean we purposely selected the district, but then within the district we randomly selected based on. I mean it was more of a stratified sampling plan because we stratified by the village.
It was proportional to size on the second stage, not on the first stage. And then why it matters? Because general population of your study and sample, they are linked through the concept of representativeness and generalizability of the results.
Right, exactly. So and I mentioned that in the limitation. So I don't think you can't generalize outside of the district. I think that's really important in the Indian context. Yeah.
Mm-hmm.
Yeah.
So it requires some challenges in description, but I think it's a very good challenge to describe it more precise and to indicate what kind of level of representativeness and sample decisions were done.
Yeah.
I think like for the major things that I would like to discuss, I already had most of the things, but perhaps the last one, when you say that there are variations across the regions, I'm very much curious about the explanations and causes why these regions are different and why we observe this difference. So I think it's very much connected to the comment of the second reviewer, who is saying that we need perhaps some more information about the regions studied so we could understand why we observe this difference. That's
I think that.
on my side.
Did you by any chance write your comments? Would it be possible for you to send them as well?
To type them and to send to you, even, or I haven't heard.
If you have, or even if you could just take a picture, that could
sure.
be really helpful.
I can summarize them.
Yeah, thank you.
Thank you. If there is any other questions, I have one question to Kristi. Like, Kristi, if you have to do this study again, out-of-pocket expenditure, how different you will do it?
Yeah, well, now that I see how interested people are of the breakdown, I think we would spend a lot more time, I think, with the disaggregation and trying to get more information about the cloth and how it was used and the food and the period. I think that there's often a lot of questions that are raised about this breakdown. So what are the women actually spending the money on? And unfortunately, I think the way that we kind of structured the tool, it was a bit crude in that sense. I mean, we had those 4 main categories and then we had the other. But I think it's a lot more from people's questions and from other tools, I can see that it has much more disaggregation, which I think we probably could have benefited from. What else? I think that's probably one of the main things. And then perhaps looking at the sampling, because I think we do get a lot of questions on the sampling, which make it a little challenging and unfortunately, takes away obviously from some of the other findings.
Okay. And what do you think about exploring this in through qualitative studies?
Yeah, no, I mean, I think this question about the what's driving the informal payments and what is it policy, is it cultural, why are there differences between District 1 and District 2, why do the women feel that they need to pay, that absolutely, I mean, we did explore that a little bit qualitatively, but I think there's definitely more that we could do. I think especially understanding the differences, because at least I don't really understand. That's one thing that I think, yeah.
Okay. Ella, do you have anything from Elizabeth?
Well, Elizabeth sent her comments on an email.
Okay.
Yeah, but I can take, because I guess it's almost 11 now, so.
Yeah.
Yeah.
Yeah, so I can take those. Thank you. For sending.
Okay, so if there is no question, we can close this seminar.
Tatiana, thank you so much. I really appreciate the comments. It's great to think about this study in this way, and really helps me prepare for my defense. I appreciate it. Thank you.
For me, it was also very interesting to observe what is happening in India, and there are some good tendencies to improve the experience of mothers to deliver.
Yeah, absolutely.
Okay. Thank you very much, Tatiana. Thank you, Kristi. Thank you, Elda and Dinansha for arranging this research seminar. And I think we would like to close this session now.
Great. Thank you.
Thank you very much.